The following podcast is part of a certified educational activity featuring Philip J. Meese, MD, MACR, from the University of Washington School of Medicine. Access the entire activity and complete the post-test at peerview.com/HYU860. Downloadable slides and practice aids are also available.
Hello, I am Dr. Philip Meese from Swedish Medical Center, Providence St. Joseph Health, and University of Washington School of Medicine in Seattle, Washington. Welcome to this educational activity on the role of IL-17 inhibitors in the treatment of non-radiographic axial spondyloarthritis. This slide depicts the spectrum of spondyloarthritis, both a historical as well as current perspective. As you know, we used to subdivide spondyloarthritis into several different subsets, with ankylosing spondylitis as the prototype disease along with psoriatic arthritis, and then smaller groups of patients having either inflammatory bowel disease associated arthritis, reactive arthritis that was triggered by an infectious antigen, as well as this bucket that we ended up calling undifferentiated spondyloarthritis for patients that really had the features of spondyloarthritis but didn't fit into one of the other categories. Now we identify patients mainly whether or not they're predominantly axial in presentation, which includes what we used to call ankylosing spondylitis, and now we're moving into calling it radiographic axial SPA. And non-radiographic axial spondyloarthritis, in which patients don't have the type of radiographic damage that is associated with more severe ankylosing spondylitis. And then on the predominantly peripheral side are the other subsets, but note that there is overlap. For example, 30 to 40% of patients with psoriatic arthritis will have some degree of axial involvement, and so have an overlap. On the right-hand side, we have a further exploration about the terminology. So non-radiographic refers to no structural damage that is evident in the sacroiliac joints or quite minimal, not qualifying for grade 2 damage of the SI joints. Axial means that there is involvement of the sacroiliac joints and or spine. And spondyloarthritis means that there is an inflammatory condition present. So there is an immune system problem that's leading to inflammation and then down the road, potentially structural damage. Axial spondyloarthritis became the standard nomenclature in 2009 based on a global study conducted by Asas, the primary organization focused on research and education about spondyloarthritis. In this particular study, they divided AxSpA into two main subtypes: ankylosing spondylitis, or radiographic axial SPA, in which patients had X-ray evidence of sacroiliitis, at least grade 2 bilaterally, or grade 3 or 4 unilaterally, but also a category known as non-radiographic AxSpA, in which the patients might have normal or nearly normal X-rays of the sacroiliac joints, but have light up of bone marrow edema from inflammation in the sacroiliac joint area, or could have HLA-B27 positivity and a number of characteristics of spondyloarthritis. In the same exercise, there was a definition of peripheral spondyloarthritis identified, and these are patients who do not have predominant back pain, but instead are presenting peripherally with peripheral arthritis, enthesitis, and have other features of spondyloarthritis. This is an older slide that suggests that there is a linear sequence here, starting with the non-radiographic stage where there's not visible damage on X-ray, but there might be on MRI scanning, and then evolving into radiographically defined disease with damage to the sacroiliac joints and spine, known as the Ankylosing Spondylitis by the modified New York criteria. Again, this implied that there was a linear progression, and we know now that not all patients who start on the left-hand side here will progress into the radiographically defined side. There are certain factors which suggest that progression will occur, including high CRP, extensive MRI changes, male sex, and smoking. Here is a more current concept figure which shows patients starting with inflammatory back pain on the upper left side of this figure, progressing into non-radiographic axial SpA. Some of these patients might even go into spontaneous remission. Some may have quiescent disease activity for a period of time, but then become more active. And then further downstream, we see that certain patients will differentiate into having frank ankylosing spondylitis or radiographic axial SpA with consequent damage to various parts of the spine, potentially in the periphery as well, and significant disability. And then there are a significant and probably similar percentage of patients that are staying in the non-radiographic category. We know that up to 12% of patients with non-radiographic AxSpA will develop signs of ankylosing spondylitis within 2 years. But many patients, for example, in the Berlin Gespick cohort, patients followed out to 10 years, fully 30% of the patients did not progress into having a radiographically defined ankylosing spondylitis. Some of the terms that have been used in the United States for this earlier stage or non-radiographic stage include undifferentiated spondyloarthritis, early AS, clinical or AS-like disease, and pre-radiographic AS. As mentioned, anywhere from 10 to 40% of patients with non-radiographic SpA will develop into radiographic axial SpA over a period of 2 to 10 years. The patients who have non-radiographic AxSpA may never develop into radiographic disease despite persistence of symptoms and signs of inflammatory illness. Some consistent risk factors are baseline low-grade X-ray sacroiliitis, baseline MRI inflammation, and elevated CRP as mentioned. Inconsistent risk factors include HLA-B27 positivity, buttock pain, and smoking. Here is the actual Asas classification criteria, which can help identify patients with non-radiographic axial SpA. We start with the stem of the criteria, which is that the patients have to have at least 3 months of persistent back pain and age at onset of the problem less than 45 years of age. And then there are 2 ways in which you can become classified. One is on the imaging side, in which there is either sacroiliitis visible on X-ray or MRI scan, and at least one of the spondyloarthritis clinical features are genetic features that are noted below, including, for example, inflammatory back pain, arthritis, heel enthesitis, uveitis, dactylitis, psoriasis, Crohn's disease, or ulcerative colitis, a good response to nonsteroidals, family history for spondyloarthritis, B27 positivity, or elevated CRP. There's also the clinical side of the criteria. So patients who are B27 positive and have at least 2 of these classic spondyloarthritis features other than HLA-B27. So here we are in the clinic and we're facing a patient that has chronic inflammatory back pain. They're often younger, and we've been referred the patient to sort out, does this patient have an inflammatory spondylitis condition? So again, on the non-radiographic side, this will be patients that have either no changes on their sacroiliac x-rays or minimal change. They may have a positive MRI with bone marrow edema on either side of the sacroiliac joint, or HLA-B27 positivity and at least 2 of the spondyloarthritis features. Whereas on the ankylosing spondylitis side, the patients will have definite sacroiliitis on x-ray and at least 1 spondyloarthritis feature. There represent significant diagnostic challenges here. For one thing, back pain is very common in humans. So you're lucky if you get through life without some degree of problem with back pain. Most of the time it's from degenerative arthritis, and therefore most of the time when a primary care physician or orthopedist, for example, is working up a patient with back pain, that's where they go in their mind. They think primarily of degenerative change, mechanical problems, maybe fibromyalgia. And this is what they think about. And they don't think or tumble to thinking about the possibility of an inflammatory immunologic spondylitis. And thus it takes a long time for patients to get to a rheumatologist, leading to this significant diagnostic delay of over 7 years on average. Whereas in rheumatoid arthritis, where the patient is presenting with swollen joints, it takes a much shorter period of time to get to a diagnosis, on average about 9 months. And so many of the patients with either non-radiographic or even radiographic axial SPA will be lingering in non-rheumatology offices or not being cared for at all. Since ankylosing spondylitis has been characterized as male predominant, 2-to-1 males over females, we have this idea that it's predominantly a male disease. So this leads to a problem for females wherein we know that more females are presenting with non-radiographic axial SPA than are men, as noted here. And this contributes to an even further diagnostic delay for women as compared to men. They are more likely to have widespread pain, fatigue, peripheral joint pain, functional impairment, and therefore a lot of times they're confused with having fibromyalgia, where that would be the alternate diagnosis. We also know that fibromyalgia can concomitantly exist with either non-radiographic or radiographic axial SPA. And so this becomes a confusing part of the patient's diagnosis. Here is a study known as the ProSPA study that I was involved in along with Atul Deodar. This was an epidemiology study in which we were taking patients that were referred into our practice with chronic back pain and at least 1 of 3 spondyloarthritis features, either HLA-B27 or current inflammatory back pain or MRI or radiographic evidence of sacroiliitis. And as you can see, the majority of patients were new referrals, and in fact, the patients that we enrolled in this study were just new referrals. About 50% of the patients. Some of them were self-referred, but look, in the green bar we see that 40% of the patients were already in the rheumatology practices that were participating in this study. They had just been labeled as back pain, but had not been diagnosed. And now that they had access to MRI scanning and so forth, it was uncovered. So it can even be lurking in rheumatology offices without being definitely diagnosed. And the majority of patients, 68% of the patients that were seen were categorized as having non-radiographic axial SpA. And this is partly because they were earlier in their disease process. Now, I've used the phrase inflammatory back pain several times, and it's part of the classification criteria. So what is IBP? Here are 3 different definitions of IBP that have been published over the years, starting with Andre Kalin back in 1977 when he was a visiting professor at Stanford, and then all the way to the most recent, the Asas criteria for IBP. So let's look at some of these elements, and these are what I run through with patients in practice. So age at onset less than 40 in this particular criteria. A STEM criteria that is required is pain for at least 3 months. Insidious onset as opposed to sudden onset, which might be a disc problem, but insidious is characteristic. Morning stiffness was dropped from the most recent ASAS criteria because of the non-specificity of it, but it's something we commonly ask. Then improvement with exercise and no improvement with rest, which helps differentiate this from degenerative or mechanical pain. Pain at night, this is one of the more characteristic features. So you ask the patient, do you ever find yourself awoken by pain? And they'll say, yes. Around 2 in the morning, I find myself woken by pain, and sometimes I have to get up and walk about in order to relieve the pain and go back to sleep. An older one was alternating buttock pain, indicating sacroiliac involvement on both sides. So if at least 4 of these 5 items are met, then the patient has inflammatory back pain with a reasonable degree of sensitivity and specificity. And this is one of the ways in which we identify patients for further screening. What else? So if we have a patient coming into the primary care office with chronic back pain, about 5% of these are ultimately going to have the diagnosis of axial SpA. This percentage increases to 14% if they endorse the inflammatory back pain criteria. And then if you apply some of the characteristic features of spondyloarthritis, that increasing the probability of AxSpA being diagnosed. For example, if the patient has a history of inflammatory bowel disease or has evidence of enthesitis, etc. And then if we get to identifying presence of HLA-B27 as well as positive imaging changes, either X-ray or MRI, that really increases the probability that the patient will be diagnosed with AxSpA. So we want to teach the primary care and orthopedic physicians that we're working with about things like IBP, maybe doing some screening with pelvic sacroiliac imaging and or B27 to try to increase the precision of their referrals to us. So we're not flooded with degenerative back pain referrals, but have a little bit more precision about those patients that may ultimately end up with an AxSpA diagnosis. Non-radiographic AxSpA can be as debilitating as radiographically defined AxSpA. Nearly half the patients switch to a less physically demanding job, and about a quarter of the patients will leave the workplace early. Now, there are a number of other extraspinal manifestations that are part of non-radiographic AxSpA, just as they are in radiographic AxSpA. That includes uveitis, psoriasis, IBD. Note that overt IBD, Crohn's or ulcerative colitis, is present in 6% of patients, but up to 42% of patients will have evidence on colonoscopy and biopsy of an inflammatory infiltrate, but not necessarily the full-blown picture of IBD. Peripheral arthritis, often asymmetric and in the lower extremities, in over a third of patients. And over a third of patients will have peripheral enthesitis, especially in the lower extremities, such as the heel. Here are some studies which show us that there is just as much symptom burden in non-radiographic axSpA patients as compared to patients with rheumatoid arthritis, psoriatic arthritis, and ankylosing spondylitis. On the left, we see patient-reported outcomes such as pain and fatigue that are from the Corona Registry, patients with these diseases, and see that there's an equal amount of burden, if not slightly more, in the non-radiographic population. And on the right, we see data showing SF36 domains, again, equally impacted in non-radiographic patients as compared to the other diseases. The pathogenesis of axSpA, regardless of whether it's non-radiographic or radiographic, is rooted in changes in a number of different cells, as well as cytokines, and in a proportion of patients, HLA-B27 has a pathogenic role. And there are a number of ways in which B27 can contribute to disease, including this phenomenon we call misfolding, but also leading to antigen presentation on immune cells that leads to an inflammatory cascade. A number of cell types are involved, including Th17 cells. We also know that Th1 cells may be involved, mast cells, neutrophils, and then there are a number of key cytokines, including interleukin-17 and TNF-alpha, to point out two of the most important. The number of different tissue manifestations are noted below, including enthesitis, that is wherever a ligament or tendon is inserting into bone, osteoproliferation, but also osteolysis. The former primarily in the spine, but sometimes in the periphery, and the latter primarily in the periphery. Synovitis in the peripheral joints, as well as the facet joints, and then sometimes gut inflammation, as previously noted. Now, if we move toward treatment, let's see what's been available to us, is currently and emerging as treatments. So a mainstay of therapy has been nonsteroidals, and the guidelines call for trying at least 2 of these for at least 2 weeks to see if they will benefit symptoms. Conventional synthetic DMARDs. In the spine, unfortunately, drugs such as methotrexate, sulfasalazine, and leflunomide do not work. But if the patient has peripheral enthesitis or arthritis, then one may try, for example, sulfasalazine. Once the TNF inhibitors were shown to be effective and really substantially effective in ankylosing spondylitis and then subsequently non-radiographic axial SpA, they really have been the mainstay of our treatment over the last 2 decades. More recently, we've seen a number of different IL-17 inhibitors become approved for ankylosing spondylitis, and more are in the pipeline. And they also have been approved for non-radiographic axial SpA. And now we're seeing the JAK inhibitors, such as tofacitinib or upadacitinib, with successful studies and coming forward in development. Here are the approved biologic medications for non-radiographic axSpA. The TNF blocker Certalizumab, which, as you know, is given subcutaneously. Common adverse events are noted here, including upper respiratory infections, rash, UTI, and a boxed warning for serious infections and malignancy, such as lymphoma or non-melanoma skin cancer. This was approved by the FDA in March of 2019. Ixekizumab is an IL-17A antagonist, and secukinumab, also an IL-17A antagonist, both administered subcutaneously with similar common adverse events. There is no boxed warning for either of these medications, but one issue that is important to keep in mind is that one can rarely see either a flare of already established inflammatory bowel disease in a patient or newly diagnosed inflammatory bowel disease. Fortunately, this is not common, but it's something we talk to our patients about. And both of these were approved in June 2020. An overview of the data on Certalizumab is noted here. 47% of the patients achieved a major improvement in the ASDAS major improvement score over the course of observation of 4 years in the open label extension. There was minimal conversion of patients from non-radiographic to radiographically defined axial spondyloarthritis. And there were durable responses with the majority of the patients who had achieved ASDAS major improvement sustain that degree of improvement. Ixekizumab in the COAST-X study showed meaningful improvement with Asas 40 as the primary response, shown here, achieved by 35% of the patients receiving Ixekizumab every 4 weeks. And this was obviously statistically separated from placebo and maintaining effectiveness over the 52-week time period. Here are some key secondary outcomes from the COAST-X study, including improvement in the ASDAS measure and improvement in the BASDAI score. We also showed improvement of quality of life as measured by the SF-36 physical component summary and ASDAS high threshold improvements. There was also corollary improvement in the MRI scans. Secukinumab in the PREVENT study showed similar degrees of improvement as we've just seen with Ixekizumab and Certalizumab showing statistical separation from placebo at week 16, and then in the US requirement to have a controlled trial out to 52 weeks, we saw a sustained benefit out through this period of time. This was also demonstrated here in the improvement in the BASDAI score. Here we're seeing the number of patients achieving at least a 50% improvement in the BASDAI, and as we showed earlier with Ixekizumab, showing significant improvement in MRI changes, a more objective marker of reduction of inflammation. So with both of these IL-17A inhibitors, we see substantial benefit, similar to the degree of benefit that was shown with the TNF inhibitor Certalizumab. The safety profile of the IL-17 inhibitors is good, with low rates of serious infection and no unusual autoimmune reactions, and just the issue of IBD that I mentioned. There were no new or significantly different side effect issues as compared to what has been shown in psoriasis, psoriatic arthritis, and ankylosing spondylitis with these agents. Here we are showing the most recent update of the ACR Spondyloarthritis Association of America and Spartan treatment recommendations for patients with active ankylosing spondylitis and non-radiographic axial spondyloarthritis. The first-line therapy should be a trial of non-steroidals, as mentioned previously, along with physical therapy. And note in red against use of systemic glucocorticoids. If the patient has peripheral disease, then one can consider glucocorticoid injections and also, for example, into the sacroiliac joints. If the patient does not respond adequately to nonsteroidal anti-inflammatories, then one would move on to a biologic agent, including an anti-TNF, or one might consider an IL-17 inhibitor or tofacitinib in these guidelines. If the patient has evidence of inflammatory bowel disease or uveitis, then we would choose one of the monoclonal anti-TNFs over the non-monoclonal TNF inhibitor. At this particular time, there was a preference for using a TNF inhibitor over an IL-17 inhibitor. As further evidence accumulates for the effectiveness of the IL-17 inhibitors, one might consider using them equally at this early time frame. And then in terms of third-line treatment, one can either switch mechanisms and go to an IL-17 inhibitor or try an alternative anti-TNF inhibitor. For example, if the patient has had a good response initially, but then lost response, i.e. a secondary non-responder. If the patient has stable ankylosing spondylitis and non-radiographic axial SPA, then the general recommendation is to continue the therapy that they're doing, such as an anti-TNF therapy or an IL-17 inhibitor therapy. And if they lose benefit, then reevaluating and considering switching medications. I want to emphasize that in all of these recommendations, non-radiographic axial spondyloarthritis is treated in exactly the same way as ankylosing spondylitis. One key point to mention is that many of the patients with chronic back pain are unfortunately treated with opioid medications by primary care, orthopedists, and so forth. And so I think it's very important to address this problem, try to get the patients off of opioids and on to a more effective treatment regimen that is not opioid-based. I've gone now through the data on treatment of non-radiographic axial SPA, as well as the basic ways in which we go about identifying non-radiographic AxSpA in the patient population. I must say that I've spent a lot of time trying to educate the non-rheumatologist in my community to potentially recognize that the patient in front of them could have an immunologic inflammatory disease, and if so, to triage them to rheumatology. Once that we see them and have a chance to identify them and make a positive diagnosis, we've had very good experience with the treatments that have been discussed here, including TNF inhibitors over the last many years, and then more recently the IL-17 inhibitors. And we're looking forward to use of the JAK inhibitors if they become approved later this year. What we are finding is that the benefit of these medications is substantial and really gives the patients their lives back. I can't tell you how many times patients have turned to me and said, with huge gratitude for getting back to a more normal state of life, being able to function more normally, having less pain, and being able to play as well as work in the ways that they used to. And for the most part, we've had good luck in terms of adverse effects and have been able to maintain the treatments for most patients. There is an issue that we may lose benefit over time, and we're fortunate that we have other drugs that are in the pipeline so that if patients lose benefit, there are drugs that are coming along that will be able to treat them effectively. That ends our discussion for today. I hope you found the activity informative and useful for your practice and encourage you to access the supplemental materials. Thank you very, very much for participating.
Thank you for listening. Download materials and complete the post test for instant credit at peerview.com/HYU860. This activity is supported by an educational grant from Novartis Pharmaceuticals Corporation. This activity is accredited by Medical Learning Institute, Incorporated. This activity is developed with our educational partner, PVI, Peerview Institute for Medical Education.